All right, why don't we get started? Good morning, everybody. And I see still the same faces as yesterday and a few new faces, so that's wonderful. And we have, as you know, a large web audience as well, several hundred on the internet. I wanted to thank all the speakers of yesterday's presentations. Quite heterogeneous in the type of methods that were presented. Some of the methods kind of exploiting the natural experiments that are happening, that the healthcare system is imposing on the patient populations and utilizing that. Insurance randomized trials, something that PCORI is also very, very interested in. And I would assume, I'm not speaking for AHRQ, but I would assume AHRQ would be very interested in that as well, utilizing data generation mechanisms that are in place already, but imposing randomization systems like that. And Natish pointed out, he made it sound like it's quite easy to do that. It was really hard work for him. I witnessed that. And Alan Brookhart, of course, speaking about the challenges when you have complex treatment strategies that is informed by biomarkers and is constantly changing over time. We then in the afternoon and later afternoon we had three presentations with mental health issues with regard to comparative effectiveness and the challenges how to study the comparative effectiveness in this setting of mentally ill patients. And was a whole catalog of problems that we heard of and no easy solutions. That was my take-home message. And of course we heard then also the Back to Health trial from Amar Bua, and again, something that I don't hear that often about, but a real challenge. How do we reach minority populations and study comparative effectiveness in those populations? And this is kind of a taste of the breadth of the methodologic issues that PCORI is anticipating. PCORI really wants to be extremely broad in its approach. When you look on the web page, you see all the variety of goals that this institute has. And PCORI was one of the few, if not the only one, but I'm not very good in history here, institution that was founded by or mandated by Congress with a methods committee or with some sort of methods entity attached to the institution, recognizing that methods are core to get it right when it comes to comparative effectiveness research or patient-centered outcomes research. But from the breadth of the topics that we had yesterday, you can already see the challenges for the methods committee with regard to the many topics that are on the plate here. And we really, Shireen said this yesterday already, we're really looking to you to get impulses of what you think are the most important methodologic issues. And Shireen also shared that there will be an RFA coming forth from PCORI, and not sharing any inside knowledge that's on the web page actually, probably late summer, maybe early fall, on methods research. It's kind of, what is it, $25 million. So that is your opportunity. We're really looking forward to application from you guys and others, of course. So, without further ado, I want to introduce then our today's opening speaker, Al Wu, who's a professor for healthcare management and policy at Johns Hopkins University. Where is he? Oh yeah, right. I was worried that you disappeared. He, of course, is leading the fields of patient-reported outcomes for many, many years and is very much engaged in comparative effectiveness research, and he's sharing his thoughts with us today, and I'm very much looking forward to that. So thank you very much for being here.
Thanks very much. For those of you who looked at the program ahead of time, this was the mystery presentation, since my official title is opening presentation. But my working title is Comparative Effectiveness Research, just add pros, ? Ahead of time, I'll acknowledge one of my co-authors, Jody Siegel, sitting in front of me, shaking her head, not really. So the kinds of information that we use typically for comparative effectiveness research are data from the perspective of the society, healthcare utilization, the clinical perspective, and the patient perspective. We collect research data purposively for research. We collect data clinically, which incidentally can be used for research. And of course, there's administrative and billing data, which many of us now use more for research than we do for the original purpose. But those data sources vary in the richness that they can give us about telling us about utilization, about clinical details, and the patient perspective. And the thing which is mostly missing at this point from all of these sources of data, for the most part, is the patient perspective. So what I'm going to talk about is, and this is my imitation of Meryl Streep imitating Julia Child from that movie, Julie and Julia, a couple of years ago. Why not just add pros to our research? I don't know what she's doing with that chicken. So why not? Why not just add patient-reported outcomes to our research? So thank you very much. Any questions? All right, I've got a couple more minutes. Different categories of patient-reported outcomes. This is from a paper by Catherine Aquadro from really a group that worked especially with the FDA to try to come up with consensus, and which actually sort of came up with the name patient-reported outcome as opposed to quality of life measure or some of the other things that were used previously. But in any event, we have data that is clinician-reported. There's physiologic data, caregiver-reported data, which parenthetically I will say is beginning to be referred to as a ClinRo. It's a little clunky, but I get the point. And then patient-reported data. They might include global impressions of health, functional status and well-being, quality of life, broadly or narrowly defined satisfaction with treatment, adherence with treatments, preference for health states or utilities. All of these things, of course, are things that the patient can uniquely tell us. A patient-reported outcome, according to Catherine and the group, was patient-reported outcomes represent the patient's report of a health condition and its treatments. I would emphasize it's the patient's report. The FDA guidance that came out a couple of years ago said a PRO is a measurement based on a report that comes directly from the patient about their health condition without amendment or interpretation of the patient's response by a clinician or anyone else. A PRO can be measured by self-report or interview, provided that the interviewer records only the patient's response. I emphasize this a little bit because there's now a little bit of an active debate. There's an Academy Health Committee that's looking at PROs and that's looking at electronic data methods. And when talking about PROs, the draft definition they came to was health data that are provided by the patient through a formal and tested system of reporting. To many of us, this seems way too broad because it does not include the critically important feature that it be directly from the patient. Some groups who, for example, do natural language processing say, isn't that a PRO? And I would say, not really. And I'll give two examples of why that is. One is, typically, this is a sample physician note about a patient-reported outcome, patient doing well. You see this typically when you read clinician notes, and this does not necessarily convey the richness of what the patient may be experiencing. Secondly, here's some data from Amy Justice, and I don't know if NIWA might have been involved in this at some point, but these are data from, these are actually provider and patient self-reports about problems with patient-reported outcomes, in this case, fatigue, common in HIV. The black bars show the proportion of patients reporting the symptom in this population, up to 80 or more percent in the sort of example. Oh, what happened in J? The white bars are the physician reports of the patient's experiences. And in the worst case, 75% of patients and 10% of clinicians reported that the patients had fatigue. So again, those CLIN rows are not really patient-reported outcomes. So going to the source, there's Julia Child. Interesting, the photo credit is by Paul Child, possibly a relative. Anyway, we can add PROs to randomized controlled trials. We do sometimes, though we don't really do it enough or regularly enough. And we can certainly add PROs to observational research, including cohort studies, and which we do some, and registries, which we do quite a lot. And I would source the now already classic AHRQ report on how to develop a registry. It's the most stolen book out of my personal library currently at Johns Hopkins. Use of patient-reported outcomes in PCOR, as the PCORI people are now prone to call it. I don't know if who's really responsible for this, Stefan. But in any event, patient-reported outcome data sources, clinical practice, individual patient management applications, including EMRs, clinical trials, observation studies, big national surveys. These are in the best circumstance, merged with clinical data to create data sets that include patient-centered outcomes. Other data on key covariates are collected, and these data can inform us about patient choice. Actually, they can inform policy decisions, for example, whether or not to fund or reimburse something, and can tell providers what they should be recommending. Sort of a preliminary example from a project of our DECIDE Center that Ebony Boulware is leading on outcomes in end-stage renal disease. There are 3 sub-projects. One, to look at the comparative effectiveness of antihypertensive medication regimens in dialysis patients. The second, earlier versus later dialysis, when should you start? And the third is iron management for anemia, which is something which is waxing and waning in sort of in the grams or kilos of iron that an individual patient might get during their career on dialysis. And we're doing some of this with UNC. In each case, we can look at outcomes, but we are, besides clinical outcomes, looking at quality of life outcomes, both disease-specific and more global or generic measures of patient-reported outcome. As you might imagine, people on dialysis are simply a little bit disabled in terms of their general functioning and perhaps their psychological well-being, but they also have some very specific problems. The same is true for dialysis, time of dialysis initiation. We're really interested in when should we start, and if there are differences in mortality, well, that'll be very straightforward. But more likely, we are going to be interested in are people's lives better over the remaining lifespan that they do have, and the difference may well wind up being in really more in quales, if I'm allowed to say that these days, than it is in simply survival or in quality of life measured at points in time. The same is true for iron. We may, because there may be morbidity involved or extended morbidity, again, looking at patients' quality of life is a important outcome that could wind up even being decisive if some of the other outcomes particularly are equivocal. In this project, we are merging several sources of data. We have national registry data from the USRDS. We have clinical data from a cohort from the Dialysis Clinics, from Dialysis Clinics Incorporated, one of the larger dialysis providers. And we actually have cohort data, which was assembled initially by Neil Poe from an AHRQ-funded Port 2 study on dialysis starting in 1994, and I'm happy to say that the cohort is still continuing. AHRQ is still getting credited, and some of the patients are still alive. We've recruited more patients also, and there are different kinds of data in all of the 3 studies, or from all 3 sources, but the choice data, and in fact the dialysis data includes some PROs. The choice data include quite detailed quality of life data, and the DCI data, everyone completes, among other things, the SF-36 at every dialysis visit, so it is possible to merge these 2 data sets. Something that I should emphasize is that PROs, patient-reported outcomes, can also be predictor variables, and they can be quite useful in those cases. Of course, confounding is perhaps the key consideration in observational research, and PROs can be useful as adjustment variables because they predict outcomes quite powerfully themselves. I won't get into sort of details of the studies, but many studies, including, incidentally, a lot out of UNC, have shown that patient reports of health, as simple as rate your health excellent to poor, are extremely good predictors of short, medium, and long-term survival. I'm going to shift the discussion a little bit and talk for this sort of the second half of my allotted time about electronic data methods. Can any of you identify yourself in that picture? This is Express Key Punch, and I think this is from about 1977. So key punching goes way back. A few people who have a similar amount of hair to me, or less, or grayer hair, are nodding. But now those key punch data can go directly into electronic health records, and I think this provides a terrific opportunity at this moment. There are a number of challenges, and I'll outline a couple of the challenges. One is there are proprietary PROs. In fact, many of them are proprietary. Secondly, there's lots of governance issues, and perhaps standard setting is sort of more the kind of governance I'm talking about, and I'll talk more about that. There is the real question. There are thousands of PROs out there. Which of them are appropriate for clinical use? That we would be willing to base a clinical decision on. There's some issues with confidentiality, which are a little special, and coordination among different organizations, I think, is something that hasn't been thought through very much yet, since we're really just at the point where electronic health records are, you might say, going viral. Up to this point, they've almost been an undetectable blip in the percentage of organizations that have an EHR, but now suddenly in the last couple of years, partly with the HITECH Act, where we're now up in respectable, maybe over 50% of large hospitals anyway, having electronic health records. Confidentiality, people are worried about patient-reported outcomes, particularly some patient-reported outcomes, in the EHR. Who should be able to see these data? Should they be treated just like any other clinical data? This is the sort of the pile of information that's need to know, and this is information that might be categorized as nice to know. And some data elements, for example, maybe shouldn't go to the clinician. Patient satisfaction data. Who did you hate today during your clinical encounter? Check all of the following. Maybe the clinician should not see that information. Maybe the patients would not answer reliably if it were visible to all. Should some of these data only be available to clinicians in aggregated form, or maybe not at all? Maybe they should go directly to research. Another question is, how do you get the data in? Patient portals are becoming an increasingly prevalent tool, and I'll talk more about that. proprietary instruments, there are many questionnaires, in order to be used, require a payment, a charge. This is particularly true for psychologically based questionnaires. The American Psychological Association and other publishers make a lot of their living on selling, renting, allowing people to use their tools. This is not so different in a lot of ways from any other intellectual property. However, electronic health records are not set up at the moment for billing people for PROs. How's this going to be done? Do you need to count every time a PRO is given and maybe even completed? It could be just like billing for a blood count, but currently it isn't. Should we only use non-copyrighted tools? Would that solve the problem? There's a certain category of copyrighted tools which people refer to as copyleft, and that means people copyright them so that they can be left in the public domain for people to use without charge. So should we only use either publicly available, including copylefted tools? I think it would be feasible to track and charge, but again, I'm not sure that people who are just adopting their EHRs want to be saddled with this additional burden. There's not so much governance at the moment because there's never really been an opportunity to collect PROs on a large scale in clinical populations. So which PROs should be used? For research is one thing. Which should be used clinically? Which are considered reliable enough that a clinician might use them? In what format should they be presented? There are questions which seem simple, but wind up potentially making differences in how people respond. Should you give people questions one at a time, or in a chunk of questions, all of which use the same response scales at a time? How will you interpret them? What should we tell clinicians? Clinicians are not familiar with these things and want to know, what should I do? When should I act based on these scores? So who's in charge of this anyway? We are, this is the beginning of a story, we are implementing EPIC. Anyone else work at an organization that uses EPIC? So we should talk more about this perhaps at the break. What we're finding out, since this install is costing hundreds of millions of dollars and many, many people's worth of time, the people who are in charge are the computer guys. They're making all the decisions about almost everything. That may or may not be appropriate. Coordination. So Hopkins now owns a bunch of hospitals, and we are all of our hospitals are going to adopt the EPIC. But at what level should there be coordination and standardization? At the level of a hospital, a health system? Some of you are privileged to belong to health systems. For all users of a common electronic health record, hold that thought. Maybe for a state, like the state of Maryland, is there a role for accountable care organizations, for regional health information exchanges, or other collaborations? This is how we're currently worked. We're siloed into corn, wheat, and health information. CRISP is a slightly tortured acronym, Connecting Physicians with Technology to Improve Patient Care in Maryland, or whatever. But this is a regional healthcare exchange which has started, and perhaps everything should be done similarly for all of CRISP. So this is an article which actually came out a couple days ago in Forbes by Shaywitz, Epic Challenge, What the Emergence of an EMR Giant Means for the Future of Healthcare Innovation. And I don't have time to get into this, but there has been a pendulum swing where virtually all of the big centers are using either Epic or Cerner. If anything, things are tilting towards Epic, with Stanford using Epic, partners just announced a couple days ago that they're going to go to Epic. We've decided we're going to do this, and a number of you similarly. And my question is, and I would, we are just starting some work to try to put this into practice. Is there some way for us to coordinate to do this, and should we try to work together? We've incidentally also been working on an alternate portal. Actually, this preceded our Epic foray, Patient Viewpoint, which is just another portal which allows doctors to order tests. And this, we've confronted a lot of the same issues ahead of time of our Epic adoption. We are working with with ProQualid, which is run by the MAPI Group, a nonprofit in France, which, among other things, specializes in translation of questionnaires, especially patient-reported questionnaires. So we are using them to, and are subscribing to them for getting information about PROs. Should this be something that more people do more widely, or should we have other similar libraries available for potentially all HIE users? Should we, for example, use the AUA symptom score, any urologists in the room, or one of the international questionnaires that's based on that? Should we only select public domain instruments? As I mentioned, questions about interpretation. What about response shifts? The fact that people may change their ideas and standards as they get sicker or healthier. What do you do about missing data? How do you link these data out to other data sources? If we get the data out of the EHR, or for that matter, if we're just looking at PRO data in published work, are there more clever ways for us to synthesize those data? So again, a lot of methodologic and use issues which need to be confronted and which have not yet, even though we're sort of really on the cusp of EHRs with, like Epic, adopting PROs. Epic includes their release 1 is going to include the SF36, or the RAND 36, since that is in the public domain, and the PHQ-9, which many have recommended be adopted for primary care use. So those things are in, and they're already going to start being collected. But the next 5 or 10 or 100 tests that go into Epic haven't been decided on, and they need to be designed. So I would wonder aloud if this might be an opportunity to partner, perhaps even with AHRQ, to see that this gets accomplished. We are thinking actively about this, and if there's anyone who might be interested in joining us, be very happy to talk. In conclusion, PRO data are collected for research and for care, and can be used for CER and PCOR. There are loads of issues, some ethical, a lot of methodologic, and a number of governance issues that are important. And I think we have an opportunity now to do research together and to partner together to facilitate their use. In 5 years, these data are going to be very valuable for doing comparative effectiveness research. Not quite yet, but I think this is the moment. So I'm going to stop with that. I'll credit Claire Snyder and Jody Siegel and Roxanne Jensen, who worked on a paper with me lately. Also Meryl Streep and Julia Child, and I can always be contacted via email. Thank you.
Thanks a lot. Any questions for Al? Yes, please. If you mention your name and your affiliation, why don't you take this?
There are very different kinds of methods of collecting PROs that might
So, great point. We are currently working a lot on the workflow, as people describe it, and that is how does the data get in, how do clinicians use it, how do patients use the patient portal, which is called MyChart in Epic speak. It needs to be figured out. As we've been thinking about it, we actually often say, well, how does anyone else do this? Does anyone know how Stanford does this, for instance? So, great point.
Hi, Jeff Cohn, Plexus Institute. I feel like there's a little bit of tension, perhaps, between the translation of PROs into any of these standardized tools versus really trying to capture what the patient specifically is looking for in the decision-making process, and then using that as a data element over time. So, for instance, if my goal in getting a knee replacement is to play tennis in 6 months, so that's really my specific outcome that I'm looking for, which is different than however it would be reflected in a standardized tool. So some way to really capture what the patient is thinking and saying.
I think there's a great point. I think that there's this sort of, what you're talking about is sort of in between patient preference and people's statements of their health status. There are individualized PROs. The CQUAL is one of them, where you can get your tennis, requirements entered into a database. So it can be done, but important to distinguish between this is my status and this is what I want.
Great. So thank you very much. Certainly feel there's lots of opportunities right now. Everybody who's interested in that should get started and speak with Al and other people. So thank you very much. And we will then start the first session. And Bruce Fireman, a senior biostatistician at Kaiser Permanente, will be chairing this session.
Well, thanks very much, Sebastian. I'm happy to be here, and I'm expecting this is going to be a very interesting session. We have 4 talks for 20 minutes each, and then I'm going to ask all the speakers to come back after the talks for a 10-minute session of questions. We're going to hear about how it can hurt us to control for the provider in comparative effectiveness research. Then we're going to hear about how to do meta-analyses with direct and indirect comparisons. Third, it's a talk on spatial analysis of where to optimize the location of medical facilities. And fourth, about an interesting source of bias in case crossover studies. Our first speaker I'm happy to introduce is Alec Walker, and he's principal of the World Health Information Science Consultants. Excuse me. He was formerly the chairman of the Department of Epi at the Harvard School of Public Health and still teaches there. He told me this morning, and is adjunct professor there. He's an editor of Pharmacoepi and Drug Safety and on the board of directors of ISPI. He's a physician as well as a researcher, and looking forward to hearing about how it can hurt us to control for the provider.
Thank you, Bruce. I'm thrilled to be here, and I just want to say thank you to Al Wu, whom I don't know, but it's been rare that I've heard an opening talk which was actually interesting and substantive, and I think that this was just a beautiful way. Well, sometimes these things happen by accident. I think it's just a beautiful way to start the day. And just another technical issue, from sitting in the audience, it sounds to me like the microphone to my left doesn't work. I'm thinking of our 500 web listeners that we probably ought to use one of the other microphones for comments. So I'd like to talk about controlling for provider, and I'll tell you in a second why this sort of came onto my radar screen. But let me back up and just with a nod to Alan Brookhart, whom I've had the privilege of working with and talking with and teaching with at various times. And I find that most of the time when I get a good idea and talk to Alan about it, he says, well, I published that in 2003. You might look at this or that. And so this is largely sort of my regurgitation of what I've learned from Alan about these things. But I think these are very, very important issues. This is the take-home message. If you take away random variation in observational research, you're in deep trouble, and we'll talk more about what we mean by that. But I'd like to take a sec on what randomization is and not think of it in terms of the process that generates randomization, the proverbial coin flip or throw the dice or the random number generator, but really what is it? So randomization is a process of treatment allocation that gives you an expectation of zero correlation between treatment predictors and predictors of outcome, or even between treatment and predictors of outcome. Okay, so if you've got that, I'm willing to call it randomization. And, the mechanics of how you did it, I think, we can say for a very interesting topic, but we can say for another day. Now, the thinking about this came up in the context of a study that John Seeger and Sebastian Schneeweiss, who are both here, and I did a few years ago, looking at the effects of a drug that was designed to promote blood clotting in patients who are getting coronary artery bypass graft surgery. And the issue that had been raised well in advance of this study was whether or not that treatment, which was designed and is effective in reducing the requirement for transfusions, might also have some deleterious side effects in raising mortality. We did a study using a very large multi-hospital services database, the Premier database, and we're able to look at the relationship between the use of this drug, aproctentan, and mortality in patients who got cabbage surgery. And this is in comparison to other agents for the same purpose. And it was basically, you could think of as a closed cohort. You came in, you got your surgery, and you either left the hospital alive or dead. We did a standard logistic regression analysis controlling for just a whole bunch of covariates, and I came with a series of point estimates. I don't want you to focus on the dose question, which is very problematic in these analyses, but simply in the fact that the standard logistic regression gave us a series of modest elevations that weren't ascribable to chance. There were many, many readers of this before it went to publication, and in fact, it went to the FDA, and then there was a lot of discussion over a year. One of the comments that we got back was that we should have controlled for hospital, that there was that hospitals certainly do vary in their degree to which they use aproctentan versus other drugs, and this is typical. Hospitals have formularies, and the formularies may choose one drug over another or give some guidance of the use of a drug. And so this reader of the data, who was Sammy Suissa, many of you know, said, well, I think you should have controlled for hospital. And so we went back and did that afterwards, and all the estimates jumped up by a bunch. And so here was the question, is what was going on here? Now, in publishing this, we chose to stick with the column on the left, which was our original pre-planned comparison, but we did report this on the right and didn't make a lot of it in that publication. We really sort of laid our conclusions on that left-hand column. For the purposes of this morning, what is important to think about is that basically we've got two analyses. One is matched on hospital and one is not matched on hospital. This is across at least many hundreds of hospitals that the analysis went. So what's going on here? Why might this result have obtained? So I want to take a step back and we'll run through some DAGs in which I am not expert, let me say. So these are maybe more metaphorical than anything else, but this is my conception of why we do different things. And the issue that we're going to talk about are what are the various ways in which the provider, which in this case the example is the hospital, might lead to confounding. So the provider might choose some exposures preferentially. We knew that was the case in the aproctentan example. And maybe the provider leads to other characteristics which are predictive in this case of death. So various protocols or treatment patterns in the hospitals might be an example, so that you have an induced association between provider between exposure and the outcome. So this leads you to want to control for provider. And in this particular case, provider is this many-leveled categorical predictor, and by control, we typically mean that we arrange it so there's no variation in provider within the analytic units that we're looking at. So we do a matched analysis or a stratified analysis. There are, of course, sort of variations in this. We can say that we can draw a box like this, but there are other forms of control, even for this thing provider, which group providers into varying degrees. And when we begin to talk about other related characteristics, then the notion of control is degree of control becomes very relevant. So I'd like to represent that here by putting a fuzzy box around providers, so that this means that depending on the study design that we choose, this thing can range from a completely uncontrolled variable to one in which we've got absolute control over that factor. And by control, meaning that this is degree in the reduction of variation. So let's go back to then what we would do for the situation of provider-caused confounding. We put in whatever kind of control we can, and the more we increase the control, the more we reduce the source of confounding. Another kind of provider-related confounding is a provider may mediate the confounding. That is, maybe sicker patients come to a particular hospital, and that hospital tends to choose a protein. And that induces an association between exposure and disease. And again, as we increase our control, we clamp down on that pathway that would generate a spurious exposure-disease association. We can imagine a situation in which the provider actually doesn't contribute to confounding at all. So doctors or hospitals have preferences, their formularies make decisions, but that's really not related to anything else about the patient. So we've got the MGH in my town makes one choice, the Brigham Women makes another choice, and it's just a matter of the formulary committee and what kinds of deals the pharmacy cut with the drug companies and things like that. It has nothing to do with patient mix, nothing to do with quality of care. It's just the way it worked out for that particular pair of institutions. What happens then when we control for provider? Well, it shouldn't affect the confounding here. There's all the pathways that lead to exposure disease associations aren't changed, but I want to ask whether it does or not. And on this, note that there was a publication 6 years ago by a number of people here, pointing out in which it just turned out, sort of looking, it was a simulation study that controlling for an instrument seemed to increase bias. So, why should that possibly be? It's not explicable at first glance as you look at this DAG. So, here's what I want to suggest. So the providers have different preferences for treatment. The control for the provider ought to be only removing a source of variation in exposure that's not predictive of anything else. Now, assuming the provider really is just that, we say an instrument, the provider is just giving rise to the treatment choice, then really it is an instrument. We'll go about this a little bit more formally in a second. Now, we know that controlling for provider in a special circumstance can induce confounding or magnify confounding that's there, and that's this so-called collider effect, which isn't a particularly big effect. Most people have tried to do quantitative studies on this, but I'd like to suggest here that the controlling for provider can also unmask confounding. We're down to 5 minutes, so let's see how fast we'll just do what we can do. So what I'd like to show you is a maybe the world's simplest simulation study. I did this on an Excel spreadsheet, generating 100 data points at random. So taking each of the, I set a variety of exogenous factors, which is the so-called unknowns, so just the random standard normal deviates driving the level of the confounder, and I took all of these as continuous variables. Level of the confounder, the level of the exposure, and then also something external to the system driving disease. And then I calculated the values that resulted. I just set up some little linear equations for each of these things, so we have the derived results. For modeling purposes, what I'm going to show you, I put provider and the other determinants of disease together and simply varied the amount of variation that we allowed that. So this, you could imagine that we're putting tighter and tighter control on provider and affecting the standard deviation of that distribution. So a smaller standard deviation of these determinants of exposure is going to correspond to better and better control for provider. It's got a limit because there are other determinants of exposure, but when you leave it wide open, there's a lot of variation, which is simply due to the provider. The system, the model is one in which the exposure leads to less disease, but the apparent confounding effect would lead to the appearance of more disease with increasing exposure. So this is the first of four models I'm going to show you. And I'm going to label this no control for provider with a relatively large standard deviation. Just these are some arbitrary units I played with for the purposes of the illustration. But this is a large standard deviation of the sources of exposure. And what we see is the exposure disease effect that we built into the model coming out pretty clearly despite a mix of data points having of disease intensity, that's on the ordinate there, the exposure intensity is on the abscissa. That relationship between exposure and disease that we built in is pretty apparent there despite the other elements of random variation. Just if you're interested in keeping track of a number, there's an R down there of minus 0.59 and a slope of minus 0.37. If I tighten up a little bit my control of provider, the association is still there, but less strong. There's more scatter. Really get down there and exert some effort in controlling the provider, and the association now becomes completely masked. Remember, the confounding is going the other direction. And if I spend a lot of money, use all my AHRQ funds, and get complete provider control, what do I have left? What I have left is only the confounded association. That's what happens when I control for provider in the situation in which the provider is effectively an instrument. Okay, how do we think about this then? There are the two sources of variation in the exposure that we might want to consider. And I'm going to think of those as the benign sources of variation, the source of pseudo-randomization, or even randomization as I defined it in the original slide. And then there's all the confounded sources, all the drivers of exposure that are associated with the outcome. So we've got these two sources of variation driving the exposure variation, and we clamp down the one that's uncorrelated with outcomes. Then all we've got left are the ones that are correlated with outcomes. And if those are unmeasured confounders, as you typically worry about when you've got a provider, then they are going to run rampant and dominate the association. But it's really, you have to be thinking in terms of the relative magnitude of the random and the malignant sources of variation and exposure, and really think carefully about what you're doing when you're looking at control. So these benign sources of variation, I've already sort of tipped my hand on what they are. These are predictors of exposure that don't cause the outcome. They're not correlated with predictors of outcome, at least conditionally and adequately on good covariate controls. These are instruments. You know, and I've listed a whole list of candidate instruments here that we frequently think about as covariates. And to the extent that they are instruments, controlling for these things is not a good thing to do. All right? It's going to unmask the confounding that's late in the data. Confounding that might otherwise be absolutely trivial now becomes the dominant source. I would note that patients themselves may also give us a matching which generates some of this, and that now the random variation is only sort of within patients. And people who have done case crossover studies suddenly have had to deal with time-varying confounders that were never really a big issue before when we were doing case control studies or cohort studies. So the message is do not control for instruments or proxies for instruments. And the Z-bias, this collider effect, may only be a small part of the problem. And also, I think we should be vigilant when we think about patient-matched designs of all kinds. So in sum, if you suppress random variation, you've got trouble. Thank you.
Yeah, I think we could take one quick question now. You did finish, and I took your first 2 minutes, so we'll give one question now, if there is one, and otherwise we'll go ahead.
Thanks, Bruce. Lovely talk, Alec. It was very clear.
For the web audience, that's Bob Glynn from Harvard.
Glynn from Brigham and Women's Hospital. I'm not sure everybody agrees that providers are perfect instruments. In the other culture I live in, the randomized trial culture, we'll commonly stratify our randomization by provider because there's a concern of different case mix, different vigilance with which providers carry out protocols, evaluate the exposures, evaluate the outcomes. I think those latter concerns are perhaps heightened in the observational setting where we assume if something isn't coded, it's not present. So I think you're correct at what we should do about it, but I think that they're more likely to be near instruments, that the providers, that there are differences in case mix that are unmeasured, that there are differences in outcome assessments, there are differences in the assessments of the confounders that are small. The patients, we generally see small intra-cluster correlations within provider correlations in outcomes. The provider treating groups of patients, they tend to have correlated outcomes, not hugely correlated. So I think in the word that Jessica Myers just did a paper on controlling for near instruments and when does it matter, and I think it gets subtle.
Time for me to answer.
I'm sorry.
I mean, this is a very important point, and I think actually I'd start with your opening sentence because I think that. With all respect, it's the source of a lot of really, really erroneous inference, and that's drawing analogies from randomized trials. Okay? You're absolutely right. To take the provider as the unit of randomization is absolutely standard in trials and ought to be, and that's a setting in which you can guarantee within provider that there's no correlation between treatment choice and patient predictors, and you do it by randomization. We have to be very careful about saying, and therefore we want an observational study to be like a randomized trial. Because the thrust of my argument is that the same motivation for randomizing within provider is the reason why you shouldn't control for provider or be very careful about controlling for provider in observational studies, is that there's a lot going on inside there, and that what you're doing is really focusing on that. And the bigger picture is, where's your randomization coming from? You know, practically the only source of real, lovable chaos in healthcare is between providers. Once you get to the provider level, there's a reason for doing almost everything. And if that's what you're trying to work with, you've got serious trouble. So the thrust of the argument is really think carefully about where your pseudo-randomization is coming from if you can't randomize, and cherish that. Is this little tender sapling with all these brambles around it, and you've really got to not whack that out with the rest of the weeds.
As long as it's entirely chaos and not somewhat directed.
Thanks for that dramatic underscoring of your main point. That was done very nicely. Our next speaker is Chris Schmidt, who recently moved to Brown from Tufts. He's done research on the accuracy of diagnostic tests. He's interested in Bayesian methods. He's done work on missing data. And his topic today is telling us exploring network of treatments with direct and indirect comparisons.
Thanks, Bruce. And I've got to thank Sebastian for inviting me. When he invited me, I told him, well, I'm moving universities, and I don't really know what I'm going to be able to do here. And unfortunately, was not able to get slides to you in time. But so I've got my new email up there. So if people want slides, please email me. What I'm going to try to do today is give you a very non-technical introduction to network meta-analysis, which probably some of you have heard about. And like a lot of the things we've been talking about over the last couple of days, this is a topic which is fairly new. It hasn't really permeated the whole research culture, but I think it's something which will have a big impact getting forward, particularly with CER. And I want to give you an introduction to it and give you a sense of why I think it will be an important technique. So we've been talking about how there's lots of complex information which is going to be coming online and is already coming online over the next decade. And in particular, for looking at comparisons of interventions, it's usually not just the case that you have two interventions. I'm talking here about systematic reviews or meta-analyses. So, typically what we've done is we've looked at two treatments. And a lot of times there are multiple treatments involved, and so the question becomes, well, how do you address all these multiple things simultaneously? And so network meta-analysis is a technique which has been proposed to do that. But you not only have multiple treatments, there are multiple outcomes. So we've been talking about patient-reported outcomes. We've been talking about quality of life. We've been talking about more biologically based outcomes. There are safety outcomes. There are efficacy outcomes. And then there's longitudinal data. So these outcomes and these treatments are being looked at in the context of not just one point in time cross-sectional analyses, but longitudinal analyses. And so all of this leads to a very multivariate type of structure. And I could get up here as a statistician and put lots and lots of equations up there, but I find as an audience member that something like that I cannot grasp on a transparency. So I'm going to try to stay away from equations as much as I can, just give you a sense of some of the ideas involved. Now, here's a network that was published in The Lancet about 3 years ago, and it's relevant. Actually, we were talking yesterday about antidepressants and how to compare them and whether they're effective or not. This was a somewhat controversial network meta-analysis where I looked at 12 different antidepressants and tried to compare them in a single analysis. And so there were lots and lots of trials in this network. I think there were about 130 of them. The way you read one of these graphs is if there's a line connecting two of the nodes, that means that those treatments have been compared head-to-head. If there's no connection, they have not been compared. The sizes of the dots sort of indicate how many comparisons were made. And so you can see there that for some of these comparisons there are direct effects. For others they're not. So we might, for example, be interested in sertraline and duloxetine. There's no direct comparison there. Is there a way we can gather information from the rest of the network to figure out what that effect is? And moreover, is there a way we can rank these treatments in some sort of order? So that's what network meta-analysis is really aiming toward. So this comes under a variety of names. I think network meta-analysis is going to become the standard. That's my sense. But it's also been called multiple treatments meta-analysis, mixed treatment comparisons, in case you've heard those terms before. And the idea is that you're going to use both direct comparisons, which are sort of standard randomized controlled trial, odds ratios or whatever, and indirect comparisons, and I'll explain what those are in a minute, to try to get a better estimate of different treatment effects and how they relate to each other. Now, the idea here is that you want to respect the randomization that's gone on if you're combining randomized trials. And typically this has been done in the context of randomized trials, although there's no reason to think that you couldn't include observational data as well. But the advantage with the randomization is that, of course, you have controlled for this confounding that we've just been talking about, hopefully. And the idea here is that you can get an estimate whether or not there's a direct comparison of those two treatments. So I'm going to try to show you that you can calculate the probability that each treatment is most effective. And compared to conventional sort of pairwise comparisons, you get better precision because you've got more data, and you can rank the treatments. And so, but there's certain assumptions under which all that's based. And so it's important to bear those assumptions in mind as we think about this technique and whether it's going to be useful. So the idea is that you have lots of these comparisons, and let's say you've got 12 treatments, so there's 100 and 130, no, 60. I can't calculate while I'm talking, but anyhow, there's 12 choose 2 for those of you who are mathematicians. Different ways of comparing these pairs, and so that's a lot of different numbers running around. So the way we think about this is think about one of these as a reference treatment. Here it's paroxetine, and think about everything being compared to paroxetine. So that's the dark blue lines. Those are what we call the basic parameters. Now, if the model is done correctly, and if there is this sort of transitivity, then you can calculate any other comparison based on those randomized on those basic parameters. And so those are called the functional parameters. So, for example, if you want to compare sertraline to fluoxetine, you can get that comparison by comparing sertraline to paroxetine and fluoxetine to paroxetine. So the difference in those two blue effects will give you the dotted red effect. And again, I'll show you how that's done in a minute. So that you don't need tons and tons of variables in your model. You just need a few. Now, just to give you a really very quick overview of what an indirect comparison is, let's say that I've got 7 trials and I've got 3 different treatments that I'm interested in comparing. And let's say in the first 2 trials, they compare A and B, and the next 2 trials compare B and C, the next 2 trials compare A and C, and then the final trial compares A, B, and C together. And what I want to do is I want to compare A versus B. So the standard way of doing that is I throw out the last 5 trials and I just look at the first 2, but of course that wastes a lot of information. So I could also, of course, throw in the 7th trial and throw out the 3rd arm. But that's the direct evidence. Where's the indirect evidence coming from? Well, the indirect evidence is coming from the fact that if I just looked, for example, at trials 3, 4, 5, and 6, 3 and 4 gives me an estimate of B versus C, and 5 and 6 gives me an estimate of A versus C. So I can get an indirect estimate of A versus B by just taking the difference of the B versus C and the A versus C. Give you a simple example. Let's say that 3 and 4 tell me that B is 10 units better than C, and 5 and 6 tell me that A is 5 units better than C. Let's say C is a placebo. Then that would tell me, well, if B is 10 better than C and A is 5 better than C, then B is 5 better than A. All right, so it's just a comparison of a difference of 2 comparisons, and that's the indirect evidence. Now, what the problem is, of course, is that you also have direct evidence. So one of the things we're going to be trying to look at is the indirect evidence the same as the direct evidence? And based on some of the talks we've heard, for example, the last talk we were talking about confounding. Well, confounding can be a problem here too, because those studies where B and C are compared may be very different from those studies where A and C are compared, and I'll give you some examples of that. So that's something that could invalidate the indirect evidence. As with all sort of new kinds of analyses, they work great if all the assumptions are valid. If the assumptions aren't valid, they don't work very great. So you really have to keep that in mind. It's not just turning a crank, it's really understanding kind of what's going on. So the indirect comparison, as I said, it's just a difference, and we can do some calculations to figure out what the standard errors of the differences are and so forth. But I'm not going to get into those details. Now, let me give you an example here of how you might use this. So let's say we've got these 3 treatments. We've got sertraline, fluoxetine, citalopram. Let's say in the first study, we compared sertraline and fluoxetine, and we got an odds ratio, or a log odds ratio, LOR here, for comparison 1. And we got, in comparison 2, we compared fluoxetine with citalopram, and in comparison 3, we compared sertraline with citalopram. Okay, so now we can get an indirect comparison of sertraline and citalopram by using 1 and 2 together, right? We can use the 2 direct comparisons to get an indirect comparison. We can then compare the indirect comparison with the direct comparison, and that would give us a combined estimate. That's what the red is. And we might then say, okay, is the combined estimate better than either one of the individual estimates? Well, it might be. if the assumptions are valid. On the other hand, it might be that the indirect estimate and the direct estimate are very different. That's not necessarily bad because that might provide us some information. That might tell us under certain circumstances, certain comparisons are good, and under other circumstances, they're not good. So what are the two basic assumptions here? Well, there's one which is called either transitivity or similarity, and that's basically says that trials involving treatments needed to make indirect comparisons must be comparable so that it makes sense to combine them. And basically, this is needed for valid indirect comparison estimates. So to give you an example, let's say that I've compared A with B, and let me say that A is a placebo, B and C are two new treatments. All right. So let's say that A versus B. These studies were done in the 1950s and the 1960s, and C versus A is a newer treatment, and those were done in the 1980s. Well, there may be differences between studies done in the 1950s and studies done in the 1980s. So it may not be valid to do an indirect comparison there because there may be confounding factors with time and processes of care and so forth that, for example, the placebo rates have changed, and so the comparative estimates have changed as well. Now, consistency says, okay, if the indirect estimates are valid and if you also have direct estimates, are those two things comparable? Or do they give you the same answer? Only if they give you the same answer can we say that they're combinable. So those are valid for what we might call mixed treatment comparisons, which is mixing the direct and the indirect. So there's a nice paper which will be coming out by Georgia Salanti, and I'll put a plug in for Research Synthesis Methods Journal, which I help edit. We're going to have an issue coming out on network meta-analysis. And so this is her sort of introductory paper, and she talks about 5 ways of thinking about this idea of transitivity. So the first one is that if you have a treatment, C, let's say, it is a similar treatment when it appears in AC and BC studies. So I already gave you an example of where it might not be because there might be a time difference in these studies. But there might be other reasons why a treatment is different in some studies than in other studies. You could think about a comparison of, let's say, cabbage with placebo or whatever you want to think of the control, and cabbage versus PCI. Well, cabbage may be a very different type of treatment in those two studies because of the way we sort of think about that comparison, right? In one case, we might have a lot of different inclusion-exclusion criteria than we might in another. A second reason would be that the missing treatment in each trial is missing at random. So if I have 3 trials, I'd like to do a 3-arm study, but I only have 2 arms. Well, if I've compared A and B, the idea is that the missing treatment C, which isn't in that study, is missing at random. Okay, it means that the reason it's missing is not related to anything which is going to be related to the outcomes. A third is that there are no differences between the relative effects of AC and BC, of those 2 comparisons, between what's observed and unobserved beyond what can be explained by heterogeneity. So heterogeneity, it means that within those trials, within, for example, all the AC trials, there's going to be differences because of factors which are operating in those studies. Well, the observed and the unobserved effects should not differ beyond what you might expect from heterogeneity. In other words, there should be no systematic differences. A fourth way of thinking about it is that the 2 sets of trials don't differ with respect to the effect modifiers. So if you think again of a DAG, that means that the effect modifiers are not differently modifying those 2 sets of effects. And actually, we just had a paper that came out in Journal of Clinical Epidemiology. I think it's in this month's issue where we explain that idea. And then the fifth thing is that the participants included in the network could, in principle, be randomized to any of the treatments. So if you have a treatment where there's one arm, which, if you think about that arm being missing, would not have been able to be used in that study, right? Then that's not going to be a valid comparison either. Okay, so I don't have a lot of time left, so let me just very quickly go through this idea of inconsistency. So here we've got 3 treatments, streptokinase, TPA, angioplasty, and we could think about the direct estimate between TPA and streptokinase giving a 0.02 difference, let's say in the log odds ratio, and the streptokinase and angioplasty giving a 0.48 difference. And so there might be a direct effect of TPA versus angioplasty, which is a 0.41 difference. When we do the indirect estimate by subtracting the 2 other arms, the 0.48 and the 0.02, we get a difference of 0.46. So here, the indirect estimate and the direct estimate are very similar. We could think that maybe they are combinable. All right. Now, if to the effect that they're not the same, that's an indication of inconsistency, and that has to hold for all loops in the network. All right. So I've talked a little bit about inconsistency, and I mentioned that heterogeneity occurs within treatment comparisons. So that's your sort of standard thing. Why do results differ within certain types of comparisons? And inconsistency here is occurring across treatment comparisons. So these are 2 ideas that we have to sort of think about at the same time. Okay. So now, so what does this all give us? Well, here we do this network, and and there's some sort of black box, some sort of modeling that gives us these effects. And so we can get an odds ratio here, for example, of these 2 treatments, mirtazapine and bupropion, that have not been actually directly compared. But through all the indirect comparisons, we can come up with an odds ratio estimate for that. And so that's one advantage of this technique. Now, here's another advantage. Here's 2 treatments which actually have been directly compared. And in the direct comparison, let's say a meta-analysis was done of those 2 studies, and we got an odds ratio of 1.15. When we do the multiple treatments effect, in other words, we take the direct and the indirect, we get a slightly different answer because now we're using information from all the other studies to provide us with, you could think of like some sort of prior information that we combine together with the studies as a whole. Again, this all depends for the correctness on whether the assumptions are valid. And then we could rank all the treatments together. So this is a little bit hard to read, but this is from that 2009 paper. So down below you have all the pairwise comparisons for those treatments, those 12 antidepressants, with respect to their efficacy. And up above the diagonal you have all the comparisons with respect to their dropout rates or their acceptability. And so this gives you a chance to look at sort of efficacy and safety simultaneously. And it's a little bit hard to see, but underlined there are the odds ratios where there's actually a significant effect, meaning that the confidence interval doesn't include 1. And so that would lead us potentially to ranking the treatments. So here's a way we can look at the probability that each treatment is ranked either in the first place, the second place, down to the 12th place. So if you look, for example, at escitalopram up in the upper right, that has a high probability of ranked first or second, best treatment. Whereas if you look, let's say, at reboxetine down in the lower left, that has a very high probability of being ranked last in both efficacy and acceptability. So again, comparing things like this, you can look at these effects simultaneously. And here are the probabilities that come out of being the best for each treatment. And so in this case, mirtazapine comes out to be best 54% of the time, escitalopram 26%. These are ways of getting estimates of these probabilities. Okay, I'm going to say a couple more things. I think I'm not going to probably get to my example at the end, but one other advantage of these multiple treatments is that you can investigate bias. So for example, you might have a network where sponsored interventions might be favored, so-called sponsorship bias. In other words, a company looking at its drug might construct the trial in such a way that its drug actually will be coming out better than it might be had they not sponsored it. Or there might be a novelty bias, which says that in a lot of studies, the new treatment will tend to come out better than the old treatment. And so one other advantage of using the indirect comparisons is that you can wash out such biases, or at least investigate them. So let me give you an example. Let's say that you have B and C, or 2 proprietary drugs, and A as a control that maybe was used for regulatory purposes for licensure. Now let's assume that AB and B and AC comparisons were done by the companies to get their drugs licensed, and those are unbiased because they're both placebo-controlled studies. But there was a BC comparison but the BC comparison is biased because it was sponsored by Company C. So Company C said, all right, well, we're going to compare our drug to B, but maybe we're going to use an older version of B, or maybe we're going to use a low dose of B, or some type of thing which might introduce bias. So now the AB trials are estimating the direct effect of A versus B, and the AC trials are estimating the direct effect of AC, but then the BC trials are estimating this bias term. And so the idea is that if you do look at the indirect comparison, you get an unbiased estimate, whereas if you look at the direct comparison, you get a biased estimate. And if you think that's going on, then by comparing the indirect and the direct, you get an estimate of that bias. Okay, so again, it's correct if the consistency assumption holds. Now, the final example I was going to give, I don't have time for, but let me just give you an idea. And again, I'm happy to provide the slides to people. And this will actually be a paper coming out soon once I get the corrections done, which is you might have situations where you not only have a network, but you have multiple outcomes. And so the example I was looking at was you have lots of statin treatments, and you want to compare them for various cardiovascular outcomes, whether they're heart attacks or strokes or whatever. You want to put that all together. So you might be able to do multiple outcomes and multiple treatments together. And I think this is sort of the future of what we're going to be trying to do, because we're going to be trying to study lots of things simultaneously. So I apologize for not being able to get to that, but again, slides are available, and I don't know if we have time for questions or you want to hold them.
Let's hold off.
Okay. All right.
Thanks very much. Okay, our next speaker is Charlie Brannis, and he's Associate Professor of Epi at Penn, and he's the director there of the Cartographic Modeling Lab. So,
just promoted to full professor.
Just promoted to full, okay.
Thanks. Appreciate that.
Here, a round of applause for that promotion.
The last time I whisper that to you, Al. Thanks so much. I appreciate it. Thanks for inviting me to talk. I really have enjoyed these presentations this morning, from the PROs on to the Z-bias and then the last one with the network analysis. It's just fascinating stuff. I want to take us in a little bit of a different direction. As was said, I'm the director of Penn's Cartographic Modeling Laboratory, which is sort of the place for geography at the University of Pennsylvania, since we don't have a department of geography. The Cartographic Modeling Lab is a joint venture at Penn between the School of Medicine, notably, but also between the School of Social Policy and Practice and the School of Design, where the architects and the urban planners sit. And so we're very interested in place and the implications of place on all manner of different things, and I would say the balance of our portfolio is really on health and medicine. And we're constantly trying to, and we're, I think, succeeding in making our medical and clinical epidemiology colleagues geographically literate. So one of the things that we've been doing over the past few years is really using a branch of geography called location science. Geography basically, as someone was talking to me about GIS this morning, GIS is one major component of geography. It is essentially cartography or map making. There's also spatial statistics, which some of you may be familiar with. But then there's a non-statistical side of geography called location science or classical spatial analysis, which is essentially a deterministic, non-stochastic approach to making decisions about space. And some of the questions that come up, and these are very much applicable to healthcare and have been used in many different industries, is about where facilities should be sited. Where should the next healthcare facility be sited? How many of these facilities should we have? How large should the facilities be? And how should demand for the facility services be allocated? These location allocation or classical spatial analysis problems are solved using a variety of different optimization methods. Linear programming is the most common, although it's frequently not successful. Excuse me. But we use something more frequently called integer programming, where we deal with facilities as whole numbers. Obviously, citing 4 1/4 hospitals is not applicable in the real world, or 3 1/2 ambulances. So we use them in whole numbers. This adds a whole nother level of complexity to trying to solve these things. When you force it you don't permit fractions in it. There are various optimization algorithms. The simplex algorithm is obviously the most famous. If any of you are familiar with it, it's considered one of the great mathematical achievements of the 20th century. And then branch and bound. And then we also use a number of heuristics, and I'll show you some of these briefly,
The heuristics that we use, because many of these models become so large, the number of options to sift through becomes so big that even the biggest supercomputer or the cloud can't solve it. And so we use a number of heuristics which find near optimal solutions. And I'll also add, for those of you who use ARCGIS, ArcGIS is the Microsoft of geographic software. ArcGIS has a new addition to it on the Network Analyst location allocation extension that will do some of these heuristics for you, and so that you can actually make decisions about location of facilities in real time. Now it's actually quite accessible to anybody. The one particular example I want to tell you about is one that we've been working on for over a decade now, and that is the trauma resource allocation model for ambulances and hospitals. And I know I was invited to give a talk, so this is a CER audience. I want to tell you first about the effectiveness and then really deal more in the comparative side of this. Effectiveness here has essentially already been established, and the first thing to understand is what I'm about to show you is the given here is that trauma is a, quote, surgical disease. That is, if you are shot by a gun or you are run over by a car right out here, the only way, if you're severely injured from that, which oftentimes you will be, the only way to definitively treat that is to get you to an operating room. There's actually very little that can be done for you in the field for severe trauma. And so time becomes a major component of this, and in that, time and distance are interrelated, so that's where we come in as geographers to begin to assist in these decisions. Now, there are two major studies. There have been several others as well. Actually, one of them is from the NSCOT study, which someone out here has on a poster from Johns Hopkins. Ellen McKenzie had done that. There's a nationwide study of 15,000 trauma patients, which showed that trauma centers and trauma center care was a significant impact on mortality by about 25%. And trauma centers are distinguished from any hospital. Okay, they are specialty hospitals, so that a severely injured patient, the thinking is, in triage in the field for EMS and ambulance providers and so forth, is that you would bypass the nearest hospital to get to a trauma center. And there's also another study recently in JAMA on the mortality benefits of being transported by a helicopter. So what we've done is we calculated these axes historically. We looked at this as driving axis for the state of Pennsylvania, and this is what people typically did. They said, here are the trauma centers with the black dots. How fast can we drive to those trauma centers? Well, that's not entirely meaningful, because you have to consider that people can either drive or fly, and there are other different geographic metrics to doing this. So if you overlay onto this map the helicopter locations, the stars here, and you make some consideration about how the helicopters and the trauma centers pair with one another, okay, you get a different sense of coverage. The coverage changes dramatically, and as you either cite these helicopters and trauma centers as same site pairings, I think it's better if I just do it here, you make a perfect circle, or if you offset them, you begin to geometrically bow down that circle into various ellipses. And this coverage allows you to better, when you think about it, allows you to better match the supply of medical care with the demand for medical care, meaning the severely injured people over that space. And also, there's some coverage from New York State, so you can also bring in spillover coverage from the neighboring state. I won't get into how this works necessarily. But what I will say is that we found some from the traditional method. So this is one example from the state of North Carolina. The Office of Emergency Medical Services did this map of basically putting circles or bandwidths around their helicopters. And they concluded they were very concerned about covering 95, which is a highway that runs right down the eastern corner of the state. Let's see if I can get that right here. So this is 95. Their coverage concludes that 95 is covered a great deal by the system, but in fact, if you do it the way we've done it, which we think is a bit more accurate, you find that this helicopter has nowhere to really fly internal to the state of North Carolina to match up with the trauma center, and this lower portion of 95 is actually uncovered. And we've gone ahead and done this for the entire United States, where we have both driving and flying calculated out, and we've been doing this each year for a good 5 or 6 years now, and in fact posting it online at a website that has been supported by AHRQ, but also by the CDC. This website is traumamaps.org. I would encourage all of you to visit it. We have both a high-resolution version, and for those of you as soon as Apple can get its act together. For those of you that don't have flash-enabled phone, you can also go to our low-resolution for devices that aren't flash-enabled. And this will let you fly in. You can do the same thing in terms of mapping it for the entire United States, or you can fly into any state, map where the trauma centers are by level, and map all the other hospitals in the United States as well as the base helipads. Zoom in, take a look at those, make some comparisons about decisions about who is a trauma center, who might be a trauma center in terms of doing some comparative simulation and changing the system. And there's various other components of this. I won't get into it. We've added a lot of tools to this where you can identify the hospitals, click on them, put a satellite image, determine how many beds, basic components of every hospital in the United States, including its trauma center capabilities. And I would encourage all of you to go explore the website. The website itself and the metrics annually have been picked up by Healthy People 2020. So now these are benchmarks in terms of getting access to trauma centers in the United States for the country that we will continue to update, possibly yearly, but probably more every 5 to 10 years. We've had some coverage in the news. Interestingly, it's amazing, any little bit mentioned on CNN has an amazing impact on people's use of and notice of what you do. This is when actress Natasha Richardson had passed away in a skiing accident. At the very end of this article by CNN, they mentioned the website and put the link on there. This is before we were on the cloud. Our visits went over 1 million visits in 24 hours and crashed our server, and resulted in a lot of nasty emails directly to me, like, you guys said this worked, and we can't look at where our trauma centers are, sudden interest in that. Time Magazine has covered this. This was interesting. We've been trying to make the case for more rural coverage, and part of doing that is making the case to people who have immense access to trauma centers. For instance, in the state of New Jersey, the average New Jerseyan has access to 21 trauma centers, comparable to maybe in the state of Nevada or other western states. So we've been making this argument about where you vacation and what's the coverage where you vacation. And then my personal favorite is Hell for Leather magazine covered us for their motorcycle lobby, and so we got a little bit of good. And they very much enjoyed the website as well. So, well, the question became then, well, so what? Who cares? You've showed us where the existing centers are, but what about the comparative nature of this? So where are the trauma centers located? Where should the trauma centers be located? Or where could the helicopter depots be located? And I want to add in helicopter depots. I don't want you to forget about this because trauma centers it's quite challenging. And when we say where could trauma centers be located, I'm not really suggesting that a trauma center be built, new bricks and mortar out of thin air. But the decision for any state about which hospital that is currently not a trauma center to be designated as a trauma center is actually quite a political and important process. So that's really what I'm talking about. But helicopters are actually quite mobile. Helicopter-based helipads are actually quite mobile and can be put just about anywhere. So there's a lot of opportunity here, and policymakers are constantly making these decisions, and we wanted to provide them with some support. Now, just like the prior speaker, I don't want to get into all the details of this, but there is an optimization model that underlies this. Basically, this is taking the entire United States, taking all the demand within block groups. And demand here, by the way, is not, we're not talking about the demand of injured people, not a direct measure of medical demand, but a measure of the population, because we think anyone is at risk of being injured. And so we want to give access to the general population. So we're trying to figure out where the population in the 200,000, where's the population in roughly the 200,000 block groups in the U.S., and which one of them are covered. And so we multiply these two, and I can go into the details, and there's various constraints that come in it. As an example, let me show you the state of Maryland, which had, this is actual coverage of demand in zip codes, not block groups in the state of Maryland. And in fact, there's very little difference in the results, whether you use actual population or severely injured people, actual medical demand. So the existing coverage for the state in 45 minutes was about 95% of the severely injured people in the state had access within an hour. We did this model where we picked up all the resources in the state, and we optimally relocated them. In this case, we were able to generate the same coverage with only a single trauma center as opposed to 8 trauma centers, and with 6 helicopter depots, the ADs as aeromedical depots, as opposed to the 8 that the state originally had. And there was another reconfiguration where we took their existing resources and redistributed them optimally and got almost 100% coverage. And so that's 5% more coverage than what they existing had, and that's a lot. That's 500 severely injured people every year that could have access. And remember, these folks are folks that would otherwise die, we think, or would have a serious mortality risk in the absence of coverage. And there are many different other options. We built this trade-off curve. This is the existing system. These are the 2 examples I showed you. And everything to the upper left are all the other configurations and comparative configurations that could be chosen. But the question says, well, so what again? The policymakers came back to us, and as you can imagine, they didn't really like the simulation of completely redistributing all the facilities in their state. And the state of Maryland, I will say, in deference to them, is one of the oldest trauma systems in the country, a state trauma system, so quite venerable and obviously would not want that sort of input. But there are advantages here. There are many more choices than can be made by any human planner. But the policymakers aren't interested, so what we really started thinking about more were smaller scenarios that they could bite off and use in the real world. And these are the kind of scenarios that we had been asked to do anyways off the cuff, things like adding 2 trauma centers. So if I am doing a competition in my state, I know where all the hospitals are, I know who's potentially eligible to become a trauma center, but I only want to designate 2 of the 30 candidates as trauma centers. Which of the 2 would give me the most advantage? So you can see this is the state of Washington. The light blue is what they have now. If you added these 2 yellow trauma centers, you would get, that would be the optimal coverage to add on as much additional coverage as possible. You could also do this with 2 helipads. This is the state of Pennsylvania. You could do it in combinations of these pretty simplistic comparative scenarios. Or you could do it even smaller, and this is actually much more common for us, is the choice of, well, I have one hospital that I'm considering as a trauma center. Should that be the one we choose, or is there a better option in the state for that one at a time scenario? And the same for adding helipads. And again, these can be put many different places. When I showed this particular map to the state of North Carolina, they were very enthusiastic, but then came back and said, this one optimal choice here for location of the helicopter is not exactly where we can put it. That's actually swampland right there. And that's very common, right? Because you can put a Kwanzaa hut and basically put a helipad just about anywhere. And we thought, we should make this much more interactive and give them more options. And a really brilliant doctoral student I said, look, why don't we do it, for instance, helipads can be anywhere. Let's do it for every small space across the state and give them a map that says, well, this yellow is the absolute best. You can imagine if you turn this 3-dimensionally, this is like a mountain range where the peak, the highest peak is the yellow, but the darkest red is 2nd, 3rd, 4th best, right? And on down the line. So they give them a very large space from within which to choose where the best location for the next facility would be. The future here is for us, and is why AHRQ is funding us, is to think about other time-critical diseases. Stroke is the one that is coming to mind most, and what we're working on very closely right now. The stroke system in the United States is where the trauma system was 25 years ago, and in fact is looking to the trauma system and the way the trauma system developed, which was actually quite haphazard. And so the stroke system and stroke center designation, we're hoping to inform that with these sorts of models and maps. And we're also going to be doing this, the website I was showing you before, we're developing a technology where instead of asking us to run the scenario for you for the hospital you want to convert to a specialty hospital or the place you want to put a helicopter depot, that we're developing a technology where you can do it interactively online by yourself. So you can say that X hospital, what if that hospital were converted into a stroke center? What would it change in terms of accessibility, geographic accessibility? And then we're also doing cost and outcome projections to accompany that given the known effectiveness we have for many of these different scenarios. And that's it. Thank you.
Thank thanks very much. And again, we'll hold questions till the end when I'll invite all four speakers up. Our fourth speaker is Jason Roy, who's at the University of Pennsylvania School of Medicine, Biostatistician, Department of Biostatistics there. He's done work on missing data and causal inference, especially in the context of dynamic treatment strategies. And he's talking to us today about a source of bias in case crossover studies.
Okay, thank you. Yeah, and, my abstract doesn't quite match the title because I was originally going to talk about matching with more than two groups, and then it turned out that I need about another month to have results. So because it's very slow to actually do matching with 4 groups if you want to do it optimally. So rather than show you partial results, I decided to present this topic, which is more complete. So, and then this is work with some of my collaborators at Penn, and whose names you see there. So so we're looking at case crossover studies, and we wanted to explore what kind of bias would come from just people sort of naturally picking up diseases and picking up medications over time, because even if they're unrelated, people just pick up comorbidities and pick up medications over time. So that's the basic idea, is we want to see what happens there. So we'll sort of just quickly review what case crossover studies are, and then get into sort of how we're going to explore this bias issue. So probably most of you are familiar with it, but the basic idea is you'll only look at cases, and then you'll look at. So there'll be a time that of this index date, which is like the time that they were diagnosed with a disease or something, and then you'll look back a little bit to see if they had the exposure just prior to disease, and then you also look back even further to see if before that they had this exposure. So you sort of compare these exposure odds in these 2 time periods. And this is useful because you can control for sort of time-independent, time-invariant confounding. So you don't have to worry about time-invariant factors because you have person serving as their own control. But the reason that we were especially interested in this particular problem is that typically in pharmacoepi studies, when people have done these case crossover studies, they always have the control period precede the sort of the exposure period for the case window, if you will, because you have this issue of the adverse event can affect future exposure. So rather than have periods of the control periods before and after disease, they typically just have it before. And so we wanted to see what kind of impact that might have. And I mentioned that there's a paper that reviewed sort of case-based kinds of studies by McClure and others that appeared in PDFs that's, I think, pretty interesting and summarizes a lot of these issues. So this is just it's sort of a diagram of what we're talking about, where you have index date, could be date of diagnosis, and then you'll have what I'm calling the case period, which is some period prior to the index date. It could even just be sort of right at the index date, or some period before that, where you're seeing if whether the person had the exposure, and then there might be a gap, and then you'll have some control period, and then you'll just sort of observe whether you sort of look for the exposure, and so you want to basically know if the exposure occurred more often here than it did here. Okay. So this can be useful when you're thinking about maybe this. I think, as Bruce mentioned, maybe this isn't quite worded right. We're thinking about transient kinds of exposures. Something that you might have every once in a while, antibiotics or something, and and then we're thinking about it more like acute kinds of outcomes. So it wouldn't be as good for sort of chronic use of medications and chronic diseases as much. I mean, because you could imagine if somebody's, let's say you're talking about a medication that if you're on it for 10 years it causes cancer or something, that wouldn't be very useful here because you would just have long-term exposure and you wouldn't have any discordant pairs. So we really need discordant pairs, which would mean like in this diagram, if you have exposure in both the control and case period, then that doesn't help us, or if you have exposure in either, it doesn't help us either. So we really want the exposure to be in one or the other if you want to have a lot of power and so on. Okay. Yeah, so I mentioned this a little bit, but it controls for these fixed characteristics, things that don't change over time. But you're susceptible to bias if there's, time-varying confounding, time-dependent confounding, and so on. So you have this exposure period, you have this case period and this control period, and some things about the person might have changed, and that could be really what's causing the exposure odds to be higher in the case period or something. So this is well known that you have to assume that there's no exposure time trend and no carryover effects and things like that. But so as I mentioned, the reason what we were interested in was this issue of that people just tend to pick up diseases over time. So even if the drug's not causing disease, you're going to tend to have more medications over time and more diseases over time, and that's what happens. So you could imagine that if you have a case crossover trial where you always have the control period precede the case period, that you probably will see an association where that might not be causal. So we're interested in sort of exploring different scenarios and when would this be the kind of problem that we should really be worrying about. When should we worry about this? Okay, so the basic questions then involve so when would this cause enough bias where we're concerned? So we're going to look at the length of the control period. We're going to look at the incidence of disease, and we're also going to look at the incidence of exposure. So how quickly are sort of people naturally picking up this disease or naturally getting sort of more medications? And also, I think these time windows are what really could be important as far as if you have a control period that was if you have a long control period, a long sort of case period, then they're getting pretty far apart. And then if somebody's naturally picking up diseases and medications, then you could have more bias. So that was sort of our guess. But we wanted to quantify this. And this was this is from the Observational Medical Outcomes Partnership, where they looked at different methods. And so this was something I found online and a graph. But they used a bunch of different methods. And right here is the case crossover. And the reason I mentioned this is just because it showed a very high false positive rate compared to some of these other methods, high dimensional propensity score, and so on. So there's a whole bunch of methods they compared. And way out here is case crossover, where they have a high false positive rate. So we're thinking if the bias is in the direction that we think it would be, that might partially explain why we're getting false positives. So this is another reason we wanted to look at this. Okay, and I don't know if I should actually, I'm calling this a simulation study, but it's actually an asymptotic bias analysis. We also are doing a simulation study, but all I'm presenting actually now is asymptotic bias. So you could think of it as simulation with large N, but either way. So, but all we're doing though is assuming that the true causal relationship between the medication and disease is null, and the odds ratio is 1. So there's really nothing going on. And then what we're going to do is we're going to simulate sort of disease using population rates for 3 different types of diseases in a sense, so rare, moderately rare, and common diseases. So we want to look at sort of 3 sort of common situations. And we're going to vary this. We're going to vary the control period based on what we've seen in the literature, and we're also going to simulate exposure based on for 3 different types of drugs, basically. So whether they're common or rare, and so on. So and then we'll look at all these different combinations of rare exposure, rare outcome, and everything in between. So this is a partial review, a very sort of some examples of case crossover studies. There's a whole bunch more, but I just wanted to show you a few of them. So we looked at what do people usually do when they have these kinds of studies, these case crossover studies, and we wanted to look at in particular what do they use for these periods of observation where you're looking for the exposure. And so these are some of the examples, but you'll see that if you look at the control periods, for example, you'll see a lot of times that they end up being 60 days or less, in a lot of cases quite a bit less. There's one example here where it was where it was a year, but in a lot of cases it's 30. You'll see some 30 days, sometimes a week, and so on. So from what we've seen, it's common to be 6 months or less, and oftentimes more like 3 months or less. But these are just some examples. And so so day 0 is the index date, and negative means how much prior to that we're looking at. Okay. And so then we wanted to look at 3 different outcomes. So we're imagining we're basically generating outcomes for people based on what we know about these either rare outcomes or common outcomes. So for a rare outcome, we chose sudden cardiac death. So we went to we found a paper that reported incidence for sudden cardiac death, and we're doing this by age. So we have these different age ranges, and then you'll see, people 25 to 34 years old, the incidence rate was 6 per 100,000. So that's what we mean by rare, and it goes up to a few hundred per 100,000 by the oldest age group. So for our rare outcome, we're simulating disease onset using these rates. So we have for a moderately rare outcome, we're using diabetes. We found incidence data from this National Health Interview Survey, and we basically, so this was from a survey, and so we had to use some of the methods that we developed in other contexts to get incidence from rates from survey data, and you'll see what that looks like. So these, these incidence rates are these dots. And then we just use smoothing to, we tried 3 different smoothers. I think we ended up using the spline, which is this pink one, if you can see it. So you'll see that people are, so it is increasing, incidence rate is increasing with age, and so people are picking up diabetes, but we're going to simulate data exactly from this model so that it does sort of flatten out, level off towards the end there, and so we're just going to generate, data for our moderately rare outcome using this rate. And then for our common outcome, we're using arthritis, and we're getting that from incidence from that from NHANES. So same idea. We have you'll see that the incidence tends to increase with age. But how much it's increasing with age varies with age, So we wanted to sort of make this as realistic as possible. So this is our 3rd outcome that we're looking at. So we see the incidence increasing over time, but the rate varies with age, and then. So So we definitely want to look at bias at different age ranges to see when it matters. And as far as exposure goes, we're basically going to do the same thing, but rather than go into the literature and try and find out incidence of drugs, we're just going to use the same 3 curves. So you could think of rare drugs as antiarrhythmic or whatever, but that's I'm just putting a name to it. But really, we're going to have rare drugs, moderately rare drugs, and common drugs, and we're actually going to simulate, from these same curves in that case, but independently. So exposure is being generated independent from outcomes. But we're looking at these. We're imagining some that are rare, some that are common, and so on. Okay, and then. So then what we're reporting is, all we're doing then is, we end up with looking at the bias. So for now we're strictly looking at bias, and you could think of it as asymptotic bias. And it's always going to result in overestimation of the odds ratio. In this case, in all of these cases, because you're picking up both things, as I mentioned. So what we're going to report then is percentage bias in each of these scenarios and for each age range. So I'll just show you some of the results. So this is an example where, let's say we have the rare outcome and we have a moderate exposure, and these are the age ranges. And then here, these are the control windows. So we range from 1 month to 1 year. And so, as an example, just to be clear what we're talking about here, these are actually percentages. So this 0.9 is 0.9% bias, so that's not something we're probably very worried about. By the time you get up to 1 year, we're talking about 13% bias. So, for example, your odds ratio would be 1.13 rather than 1. Okay, so that might be something, well, I'm sure that is something you would be concerned about. So what we see is we're not seeing as big change, and for most cases we're not seeing large changes with age, although there's a slight downward trend here for this particular outcome. But we do see by the time we're talking about a year, if you had a control window of a year, we're seeing the kind of bias that you would definitely be concerned about. In 6 months, it's still a little iffy. Like that might be more than you'll be happy with. So based on that, it seems like, a 3 month or less window would be pretty reasonable, and we'll see this pretty consistently across these different cases. So we have moderate outcome, rare exposure. Again, we're seeing you can sort of get up to in the neighborhood of 10% bias once you get out to the 1 year mark, and we have rare outcome, common exposure. And you'll just see that we're getting the same basic story in all these different cases where at 6 months you're getting somewhere around 5% bias, and a year you can be pushing up to 10% bias in these different cases. So yeah, same story for all these different things. So I'll just finish up with basically. So we're. Based on that, we would be recommending, at the 6 months or less, probably more like 3 months or less for these windows of time. But even a small amount of bias could affect type 1 error rates, especially. And so we're looking at finite samples, what the impact would be, but that I'm not presenting here. And then I also wanted to mention some other designs because an alternative. Well, there's a few things you could do. You could sort of adjust for. You could just if you know whatever disease you're looking at, you sort of know what the incidence rate is. You could probably do some kind of an adjustment, but there's some more direct ways of doing it. There's this case time control design, which can solve a time trend problem, but also can introduce bias. So this was discussed by Greenland in '97 and so on, like what the sort of issues with that are. There's also self-controlled case series, and more recently there was a case time control design was proposed where controls are from basically restricted to future cases, and so I think that seems promising. But so we're currently looking at other designs and seeing and looking at trade-offs and seeing whether that solves some of these problems. But so I guess I'll end there.
Come and sit up there in the panel, and for those who have questions, why don't you go to the mic and identify yourself. Is this one working here? Yeah. Okay, good.
You have a question for Dr. Walker? Can you hear me? Oh, sorry. Nai-Hua Duan, Columbia University and the New York State Psychiatry Institute. That was a very elegant presentation. Thank you. I thought it might be useful to relate the discussion. Talk about, I guess, the role of the provider in this kind of multi-level studies where patients are nested within providers and providers are nested, I guess, maybe in larger care systems. With, I think, some of the related discussions in the disparity literature where, I guess, in some studies, it's potentially possible to find that the quality of the care patients receive by patients of different minority status received within the same care setting might be similar. So on the individual level, there's no disparity, but at the site level, the quality of the site that the minority patients or high minority neighborhoods might be different. So in a sense, in that situation, there are two kinds of exposures. One is exposure to disparity at the individual level. Another is exposure to disparity at the system level, where the neighborhoods might be served by different quality care providers. So in that situation, maybe the potential difference when you do or do not control for provider might not necessarily in that situation be a reflection of a confounding problem, but it might be really answering two different questions related to two different exposures.
Yes, thank you. That's an important point. What you're talking about is a situation in which different providers are expressions of access to care, quality of care, by virtue of the institution they work in, and so they're mediating another effect. And if you match on that, then of course you're going to lose the effect you want to study. And so I completely agree with you.
Maybe I can clarify. There are really two different effects.
No, I understand. And I think that the provider mediates the effect that you want to study, and when you match on provider, you're matching on an intermediate variable, and you can't study it anymore.
Alan Ellis from UNC. A couple questions. First is for Chris Schmidt about the trauma centers. I'm wondering if you gave any consideration to types of trauma that are more or less preventable. I mean, some are more. Some are more preventable than others. So if there's any consideration given to that, and also to areas where there's more trauma versus areas where there's less trauma. Oh, I'm sorry, I got the wrong speaker. So in urban areas, for example, might have more trauma due to gunshot violence or to car crashes or things like that, but those are also more preventable. How do you address those issues?
So the model is, when you're talking about prevention, I think you're talking about primary prevention, and we have a whole other branch of study that deals with that. This is what I showed you is really dealing with medical care of trauma once it has occurred, so not preventing it outright. In terms of higher prevalence of trauma in certain areas, the models are completely designed to account for that. So the goal is, the spatial profile of trauma, where it occurs in a state or across the United States, is fully accounted for in the models. And of course, there will be large peaks in cities, and there will be much less trauma in rural areas. So the model accounts for that, but in a sense, we are working on, and we have a couple of studies that have been published looking at the matching of that level of demand, that supply, that level of demand, and the supply of the trauma centers, and the amount of capacity that each of the trauma centers has, in terms of the beds, or more importantly, the critical care beds that the centers have to account for the demand. So instead of, in that case, the models are going into, in a sense, not simply the facility, but the beds. There's more of a metric and more variation per center. But of course, that's introducing a great deal more complexity to these models, and we're working on it. So
Thanks.
That's a great question.
Other question really is for Chris Schmidt, and it's about the network analysis, meta-analysis. In deciding whether the direct comparisons or the indirect comparisons are consistent with have consistent findings, it seems like it would be important to look at practical significance or clinical significance as opposed to just statistical significance. And I'm wondering if there are guidelines about that, or if you have thoughts about that issue.
Yeah, no, that's a good point. I mean, this area is very new, and it's undeveloped. And one of the things, actually, in terms of writing a paper for the supplement, one of the ideas I had is just to kind of put out all the different issues that need to be considered. And it's funny because when I was listening to the talk on the trauma, I was thinking, well, we could sort of use the same idea to figure out where's the right place to put the next study. If you could come up with some, I mean, with trauma centers, there's sort of a nice geography already there, right? You've got roads and you've got swamps and whatever, but how do we do that in terms of studies? And I think there's a whole series of questions there about kind of what's the right place to put the study, and then what's the right metric to measure that on? Is it as you say, statistical significance? Is it clinical significance? And that could vary depending on what the question is, what the comparison is, or what the treatment the effect modifiers are going to be as well. Because you can think of, in some circumstances, an effect might be big, and in other cases it might be smaller, but it might be of more importance, even though it's a smaller effect, because it has a more important cost effect.
Darryl Gray from AHRQ was interested in terms of the trauma analysis, the degree to which you were modeling time as a function of traffic or road conditions or things like that, because obviously I guess Bruce Goodman and people at Dartmouth have developed some software for being able to convert distance into actual time as a function of those conditions. I also don't know whether there's a further level of complexity looking at seasonality and the degree to which, depending on the season of year, and in some states that's actually going to have more of an impact on travel time than it would in other places.
So the answer is we have two modes of transportation. So again, I was saying we were working in distance because we're geographers, but all that distance is converted into time. There's a lot of studies that we've done, a couple of meta-analyses, to figure out what are the time constraints on average for the U.S. for various types of ambulances. So for instance, all the models I showed you incorporate how much time a ground ambulance crew, an ambulance that drives around, takes on scene with a severely injured trauma patient versus how much time a flight crew, when they land on a scene, takes with patients. So those sorts of, and the warm-up times of the ambulances and all that's incorporated into as well. But I think the times you're talking about are the transport times. And so the transport times for the helicopters, it turns out, are pretty easy. I mean, they're straight lines, right? There's no congestion in the air for the most part. There are some landing zone issues in terms of finding a landing zone, but we've incorporated that into it. So the real challenge is the driving time. And I don't know what the folks at Dartmouth have done, but there isn't a whole lot that's nationally available that accounts for congestion. We use the standard shortest path algorithms that essentially were developed in the 70s, and these are the same ones if you put your GPS in your car, and it'll tell you the fastest way to go from point A to point B given the road network that's before you. Thus far, we don't have good national timely data on congestion for every road in the United States. We've been working with a couple of commercial providers to try to get that so that we can bring it to bear. But right now, our driving calculations assume, as do anyone who's doing this really at this point, assume that you pick someone up at point A in the U.S., flying at the speed limit of that road. They get picked up. There's no stopping along the way. and then you drop them off. And in fact, we've done some, and other people have done it too. It's not that far off from the congestion parameters internal. Now, there are seasonal congestion parameters. There are daily congestion parameters that also need to be brought to bear in all this, and we haven't found a way to incorporate those in. I'll say that probably a good way to do it is to leave the deterministic optimization world and begin to have more of a stochastic approach to this in terms of what are those parameters and when do they typically happen. But thanks for that question. It's a really important question.
Do we have any more questions?
I have a question for Chris, and I was thinking of the 5 ways of thinking about similarity, and I was actually very concerned by the last one, which was that all the patients could have equally participated in any of the trials. And I see how that generates similarity, but I'm concerned that if you use it as a criterion for similarity, that it leads you to throw out almost everything, and it could be used by critics of your method as saying, well, they brought in a lot of stuff that they really shouldn't have put together.
Yeah, no, this is really it's sort of a proposal, and I'm not sure that, I sort of have to work out the mathematics as to whether, it's really required, and whether they're sort of mathematically equivalent. I think it's sort of one heuristic way of thinking about it, and this is, again, when the main message I was trying to get across is that these new techniques seem very good, and it seems like a great, oh yeah, let's put everything together in one network, but you really have to think hard about whether that network is valid, and that's one of the considerations. And I agree that you don't want to have to throw everything out, but on the other hand, I do think you have to think about whether, if one trial doesn't include a couple of arms, or in the example I gave where there were 12 different treatments, you're not going to have a 12-arm study. So does it really make sense to have those treatments all together in the same trial?
Also, it seems to me that this is an area where random effects models would be useful, and that sort of the assumption that your information is getting better and better as you get more studies doesn't really allow for the fact that they could be somewhat contradictory to one another.
Mm-hmm. Yeah, and I didn't really bring up Chris sort of mentioned I tend to do Bayesian analyses, and I didn't really want to get into that discussion, but I think prior information here is something you might be able to make use of.
Yeah.
So.
Thanks. Any more final questions? I think we're coming up near a break time, so I want to thank the speakers for a great talk.
We will continue at 10 to 11 sharp.